Hello everyone in CardioMinds channel, and we are still in the topic of the guidelines of cardiovascular disease prevention, and we are going to start the risk factors intervention. We remember this diagram that we have discussed as the first video of the guidelines. We mentioned that the prevention goals is for all population, and we divided them into apparently healthy, patient with established cardiovascular disease, and patient with a specific risk condition, putting into consideration the presence or absence of risk modifiers or comorbidities, and so we can perform accurate cardiovascular risk estimation followed by informed discussion with the patient regarding lifetime risk and treatment benefit, so we can reach the personalized treatment decision followed by individual level intervention and population level intervention, all aiming at reduction of the cardiovascular disease burden. As we are starting to speak about risk factor intervention, what we need to focus on is this point, that up to 50% of patients who received appropriate risk information regarding risk estimation and regarding treatment benefit, they choose to forego the proposed intervention regarding lifestyle modification and medication. And some patient on the opposite side with low to moderate risk may be highly motivated to decrease the risk even further, although the risk is much lower. So this means that the compliance is variable and is not related to the patient risk. It depends on the doctor-patient relationship. So we can consider the treatment recommendations are never ever to be imperative, as in the form of an order to the patient for high risk or very high risk categories, and they should not be prohibited for patients with low to moderate risk or may be very motivated to decrease the risk even further. That's why a good discussion with the patient is essential. So we need to have personalized presentation of the guidelines, which helps the patient to understand his own condition and his own risk, encourage him to start lifestyle change, and improve his compliance to the medication. And this can be achieved by his doctor, but we have some barriers to achieving this. First of all, some patients may have impaired ability to adopt a healthy lifestyle depending on his cognitive and emotional factor. Also, there are some factors like the impact of the diagnosis, impact of symptoms, the socioeconomic factors, educational level, mental and psychological health, which may affect the patient compliance and impact his motivation to start lifestyle changes. Also, the perceived susceptibility to illness and the anticipated severity of the consequences of the disease and also of the medication. Some patient may be not convinced that his disease is severe enough that he need to have lifestyle changes, and some patient may be over anxious or maybe even obsessive that he are having severe illness, and so they are much more motivated to have lifestyle changes. So the question that forces itself upon our minds, how to improve patient's motivation? First of all, we need to have a motivational interviewing with the patient. It is not just a list of instructions that I give to the patient, or I send him a message on the mobile phone that you need to have 1, 2, 3. I need to discuss with the patient the needs for lifestyle changes. I need to discuss with him his risk to develop cardiovascular disease, and so he is motivated to start the treatment strategy. Also, the consultation session may include a family member or a friend to the patient, especially for elderly population. This helps them to understand the patient's condition, and so they can encourage him at home in order to adopt these measures. Connection is of paramount importance with the patient, and this emphasizes the importance of a doctor-patient relationship. I need to focus with the patient before greeting in order to understand his own condition. Listen intently to the patient with good focusing on the patient's symptoms and the patient's problem and his fears. Also, I need to agree on what matters most, because it has the first priority to be achieved in his treatment strategy, and connect with the person's story, not just with his clinical symptom. I need to understand his background regarding socioeconomic status, regarding psychological status, in order to understand what are the challenges that may face this patient to achieve the treatment strategy, and explore his emotions, his concerns, his fears about how to implement these changes. By this way, I can understand what are the measures that are easily to be adopted and what are the measures that may face difficulty with the patient in order to be adopted, and so I can improve his motivation, improve his adherence to the treatment strategy regarding lifestyle and medication. One of the helpful principles in this issue is the ORS principle, standing for open-ended question asked by the doctor to the patient, then affirmation, as the doctor affirmed to the patient what has the much more priorities regarding the treatment measures and lifestyle measures, reflective listening performed by the doctor in order to understand the patient condition, the patient's symptoms, the patient's concern, and then summarize to the patient what are the specific measures that he needs to start to adopt in his lifestyle. This helps the patient to present their perception and help clinician to summarize the goals for the patient in a clear way so the patient doesn't get confused about the large amount of information given to him and he doesn't remember any one of them. Also, the SMART principle is helpful to be achieved with the goals, as they should be specific, measurable, achievable, realistic, and timely. This helps to set the goals for the patient for behavioral changes, and so the discussion with the patient is paramount in order to set specific goal for each type of patient. Not all the patients are the same. What goal may be achievable or realistic for one person may not be achievable or realistic at all for another one. That's why the doctor-patient rapport is important to understand the patient's background, his socioeconomic conditions, psychological status, so I can tailor the treatment goals for each patient according to what I discussed with him. And one of the most important challenges is the medication non-adherence. The percentage, of course, is higher with secondary prevention, as here the patient has already established cardiovascular disease, so he is much more concerned to reduce residual risk. But in case of primary prevention, the patient may be reluctant to achieve treatment measures because he is apparently healthy. I need to think what are the contributors to non-adherence in order to try to combat them. The first cause is the polypharmacy and the complexity of dosing regimen. For example, about medication need to be taken 3 times or twice per day rather than once per day. The higher the number of prescribed medication and number of dosage, the higher the percentage of non-adherence. Also, the financial aspects. If I prescribe to the patient medication which are too expensive to him, at that time the patient cannot get the medication, and it is the doctor's responsibility to consider this issue when he is prescribing medication or offer to the patient another way in order to get the medication in a cheaper price. Also, the poor doctor-patient relationship. When I'm speaking about the doctor who speaks to the patient in a judgmental way, he just gives him order in order to achieve without considering any other factors that may impair his compliance. The patient is not convinced with this treatment strategy, and so he will not achieve any part of this. And always try to avoid the use of this term, which is stop, 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 because this may get the patient frustrated. I need to understand that some of these measures may be easy for the patient to implement and some measures may be difficult, so I need to give him a realistic target to achieve by reduction of the unhealthy measure. Then I can reach the target of stop these unhealthy measures. Lack of disease acceptance in some patients may impair his compliance to the medication or the lifestyle measures because he is not convinced that he has a disease or he has a risk for a future disease. Also, beliefs about consequences and side effects of some medication. One of the most important beliefs that statins cause muscle pain, so I will not take them because one of my friends developed muscle pain, so he may not take this medication even if he is having very high cholesterol level. Cognitive abilities and mental disorders in some patients plus physical limitation or living alone. This is an important challenge in elderly population which may impair their compliance to medication. Also, depression is very important risk factor to non-adherence, so I need to understand these contributors in order to combat them, which may help to reduce risk and motivate the patient to increase their compliance. This emphasizes the importance of the communication with the patient regarding these challenges so I can improve compliance. One of the easy ways that I can offer to the patient is some mobile application which may improve adherence to both medication and behavioral change. They are easy and cost effective regarding their use, so I can offer them especially to elderly population. So all this discussion drags us to an important class 1 recommendation in the task for this year, that the informed discussion about the cardiovascular risk, about the treatment benefit is essential, and they should be tailored to the needs of the patient, because not all the patients are the same personality. So I can have realistic goals, and so I can reduce the burden of cardiovascular disease at the patient level and at the population level. So what we can conclude today from the first video in the risk factor intervention, that what is more important than starting risk factor intervention is to build a good rapport with the patient that gets him convinced with his disease, with his risk, and so he will be convinced with the prevention and treatment strategy regarding lifestyle, regarding medication, and so I can achieve optimal targets for this patient. So this is not less important than prescribing medication or just giving the patient some instructions. Thank you very much for watching this video, and we are going to have much more detailed videos regarding risk factor intervention.